Okay. How about some miscellaneous agents? Adenosine, magnesium, digitalis. These don't fit into the classic kind of Vaughan-Williams classification scheme, but they're really useful in terms of their ability to be anti-arrhythmics. Okay. Adenosine is a naturally occurring nucleotide. It's administered as in a rapid kind of IV bolus, and this will really, really quickly terminate those supraventricular arrhythmias that are re-entry. All right. Adenosine is a really good friend of mine because it saved my son's life. My son had an SVT about 9 months ago. He's 5. He came out of the play bin at Chuck E. Cheese holding his chest. I thought he had fallen. And I checked his heart rate, and it was 220. I mean, I couldn't even count that fast. I knew it was really high. So we took him to the emergency room. The vagal maneuver did not work. His heart rate was 275 when we brought him in. And this adenosine, so the vagal maneuvers did not work. And so you know if you stimulate the vagus nerve through a whole bunch of different muscle exercises that the pathophys people can shed more light on, you can convert a patient out of an SVT supraventricular tachycardia or atrial arrhythmia. So this drug very quickly took that SVT away. He was back to normal in about 1.5 minutes, 2 minutes, which is about the amount of time, if you give something IV, it takes to completely kind of circulate through the body. Mechanistically, how does this drug work? Well, a couple of different things. So it'll activate the acetylcholine sensitive potassium channel so that it's really kind of a super vagal maneuver in terms of a chemical itself. You'll see mechanistic effects on the atrium and the SA node as well as the AV nodes themselves. It'll hyperpolarize those tissues. It'll shorten that action potential duration, which is graphically depicted on this slide. And it'll slow the automaticity rate. Okay? And so here you see an inhibition of intracellular cyclic AMP, and that's going to inhibit norepinephrine binding, and you'll see a reduction in calcium current, and so that will increase the AV refractoriness. And so adenosine, great drug, it's cheap. It goes in, it terminates the SVT, and very little to no side effects afterwards. So this is kind of a nice drug compared to all the other antiarrhythmics that exist. You can also see this drug used for kind of controlled hypotension, to kind of induce hypotension in a cardiac-related surgical procedure. And so again, this is a great drug because it's got such a short half-life. The side effects and the toxicities are short-lived anyway. There is a drug type of interaction with methylxanthines, which includes theophylline or caffeine. These block adenosine receptors, and so larger doses would be needed if these drugs are co-administered. And so luckily my son does not drink a lot of coffee like I do, so he did not need larger doses of adenosine. Okay. Magnesium, you can see magnesium being used, and this is really efficient specifically to terminate torsade de pointe. All right. Here you see kind of suppression of early after depolarizations or EADs because of the blockade that magnesium has on the sodium calcium channel. And then this is also kind of dose dependent. And so look at really, really high doses of just magnesium. So this is just, Epsom salt, right? High doses of magnesium can induce cardiac arrest after respiratory paralysis. And so small amounts of magnesium will be observed on changes in the EKG. But especially with torsade de pointe, this is a really effective, cheap strategy to kind of treat some of those conditions. What are the drugs that are known to induce arrhythmias? Well, when used inappropriately or at high doses, digoxin or digitalis. Beta blocker withdrawal, so we talked about, if the patient's on a beta blocker for whatever, any of these cardiac diseases, and they decide, hey, you know what, it's been 10 years since my heart attack, I feel great, I've lost weight, I'm going to stop taking my beta blocker on Tuesday, because why not? If they have an abrupt withdrawal of that beta blocker, you can actually see these arrhythmias become more and more evident. So if a patient needs to go off of a beta blocker for whatever reason, whether it's their decision or yours, they need to be tapered off of it very slowly over the course of several weeks. One of the things that you should remember, and this is a good rule of thumb for all pharmacology, is that when you supply an antagonist, doesn't matter what kind, the body's corresponding response to that is an upregulation of whatever receptor you're trying to get rid of, okay, or trying to silence. So in the case of a beta blocker, 20 years on a beta blocker combined with abrupt withdrawal is going to produce a really hypertensive patient, okay, and the heart rate's going to be through the roof, okay. Other drugs that are known to induce arrhythmias include theophylline, which is one of those xanthine oxidase inhibitors used basically in asthma. Verapamil, diltiazem, quinidine, flecainide, all these drugs, although they are anti-arrhythmic medications per se, when you give them inappropriately or if the patient has some underlying dramatic structural heart damage, you can see some of these agents induce arrhythmias. So what does that tell you about starting an anti-arrhythmic medication in a naive patient? Naive meaning never been treated before. Okay. Do you tell them to fill the prescription at their pharmacy and wish them good luck, or do you keep them in the hospital? You should probably monitor them for at least 24 hours with EKG to kind of make sure none of these pro-arrhythmias are going to be induced by some of these drugs. And that's what they do. And so many times when a patient is put on an anti-arrhythmic medication, there is some underlying cardiac pathology anyway. So you have to work them up, and that usually takes some time. So they're usually in the hospital anyway, okay? Now my son, when he had the SVT, he was not hospitalized or he was not admitted. He was only in for maybe 2 or 3 hours. Heart rate fell to normal. There were no side effects and toxicities. EKG looked beautiful. It was the end. So there was no reason to hospitalize him. So let's talk a little bit about digoxin. And so this is kind of this is a weird drug that you don't really know where to put it. It used to be kind of frontline therapy for a lot of different diseases, and it's kind of fallen out of favor for good reason. And so digoxin comes from this really nice plant that actually grows in my garden. It's the only thing that the damn rabbits won't eat, so you know it self-seeds everywhere. And it is a cardiac glycoside, and so basically it's poisonous. Okay, it increases the slope of phase 4. Okay, and it'll increase the rate of automaticity, especially in the context of low potassium levels. All right. Mechanistically, we say this is a sodium-potassium ATPase pump inhibitor. All right. And here's the sodium-potassium ATPase pump, and digoxin sits in there. Okay. Where do you see this drug used? Well, for controlling ventricular rates in patients that have atrial flutter, atrial fib, with underlying heart failure. Okay. So it's a very specialized or specific patient population. It has a very narrow therapeutic index, so there's a very fine line between dosing the patient and killing the patient. Okay, but it will decrease AV nodal conduction. Okay, so here's that calcium sodium exchanger. Okay, so here you see calcium and sodium being moved out across their gradients, and this ATPase pump relies on the sodium gradient to pump in potassium. Okay, and so what digoxin or digitalis does is it actually inhibits the activity of this pump. Okay, and so this drug now makes this cardiac muscle positively inotropic. Okay, so if a beta blocker reduces the amount of serum, the amount of calcium inside this myocardial site, it's a negative inotrope. Okay, digitalis increases the amount of calcium available. Okay, and makes it a positive inotrope. Okay, and this is why it's used in heart failure. Okay, and we'll talk about the indications of digitalis or digoxin in heart failure, but specifically it's heart failure patients that have underlying arrhythmia problems. It's not just your standard of care for heart failure patients. And in fact, since we're on digoxin anyway, when you look at the clinical data for digoxin, patients that are on it typically don't fare better being on this drug, which is unique because all the other drugs, beta blockers, ACE inhibitors, diuretics, aldosterone antagonists, all of those drugs actually have clinical data that says when you put cardiac patients on them, they live longer. Digoxin, some of the data actually says they live shorter periods of time, but you really have nothing else to treat them with. So this is kind of a unique drug class. It's falling out of favor in terms of its number of prescriptions written per year, but it's still clinically relevant. There are still physicians who will use this drug for, again, for the specialized population of patients, and you'll see them in the wards. You will probably not be writing new prescriptions for digoxin because it does require some experience. And so, you know, if you do decide to elect to put a patient on digoxin, the attending, I'm sure, will be kind of over your shoulder to help you manage them, because it is a little bit tricky. You'll see AFib and aflutter for this drug used for, kind of controlling the rapid ventricular rate. It has other outcomes due to its mechanism. It's going to impair ventricular filling, okay? And it's going to decrease the filling time, which is going to reduce cardiac output, okay? So from a heart failure perspective, that doesn't bode well in terms of what we're going to talk about tomorrow with heart failure. But again, remember we talked about the heart failure patient with an arrhythmia, which is a specialized group of patients, okay? We have to control ventricular tachycardia because eventually, if it's left untreated, it's going to lead to heart failure, which is why we have to use this drug, okay? So digitalis is useful for kind of controlling that ventricular rate when it's being driven by a very fast-paced atrial rate. So here the atrial tachycardia is driving the ventricular tachycardia, which is going to reduce cardiac output, okay, and then exacerbate heart failure. So see how all four of those are connected? That'll become a little bit more evident tomorrow when we go into the nuances of heart failure. All right. Mechanistically, digoxin can also activate the vagal efferent nerves, all right? And this is the one that's under parasympathetic control. So vagal activation, again, this is the 9th cranial nerve. It's going to reduce conduction of electrical impulses, and this is all mediated by acetylcholine. Okay, when this occurs, fewer impulses reach the ventricles, and then the ventricular rate falls or plummets. All right. Digoxin can also increase the effective refractory period within the AV node. So there's lots of mechanisms of action of digoxin, and this is why this drug will work, but it's so problematic in terms of management. All right. Here's again some of these mechanisms of action. So it will increase intracellular sodium. That leads to the accumulation of intracellular calcium, which leads to basically more calcium being available inside the heart for increases in contractility. So it's positively inotropic. Will inhibit the sodium-potassium ATPase in the vascular smooth muscle, and that'll cause depolarization. And so here you'll see smooth muscle contraction and vasoconstriction. And so lots of different mechanisms of digoxin. And as I said, relatively a narrow therapeutic index, so it's a really unsafe drug. It's got a long half-life. It sticks around for a long time. There's numerous drug-drug interactions, and it can actually, in terms of alterations in patient status, can actually precipitate an arrhythmia, which is why you need experience if you're going to manage a patient on this drug, especially in patients that have atrial tachycardia and AV nodal block. So, we talked about the patients who can get it, who can't get it. Patients who are or can be at any time low potassium, patients who have AV block or the Wolff-Parkinson-White syndrome, which is a rare syndrome. And basically, we're going to, if we look at our left ventricular ejection fraction curves, looking at, this is pressure versus volume. You showed them this loop in physiology a million times, right? So now we're going to actually use this as kind of a target. So a lot of our drugs that can increase contractility, or drugs that are positive inotropes like digoxin, can actually kind of shift this curve, and so you can see what that looks like in each of these different cartoons. And this is kind of a nice summary chart looking at all of the different molecular or physical targets in terms of anti-arrhythmic drugs. So in the context of sinus bradycardia, okay, so if the patient's got very, very low heart rate, we can use atropine, okay, IV, and it's going to have a negative or an inhibitory effect on acetylcholine in this SA node, and it will rescue the bradycardia so that we restore normal rhythm. If we've got ventricular and supraventricular arrhythmias, we can use class 3, class 1A, or class 1C drugs, okay? And so here we're going to mechanistically favor targeting the phase 0 and the phase 3 slope. Ventricular arrhythmias can be treated successfully with class 1B agents, and lidocaine was really kind of our favorite in that category. And supraventricular tachycardias can be eliminated with adenosine, digoxin, or verapamil, and we'll favor adenosine just because of its reduced likelihood of drug-drug interactions. Stress-induced arrhythmias can be managed by long-term beta blocker activity, okay? And let's see, I think we've got everything else covered here. and more drugs can inhibit the refractory period. So this basically kind of combines what we've been talking about in terms of a summary chart or an idea map looking at all the different molecular targets. Let's kind of quickly go through some of these. So the class 1A agents are going to block the sodium channel, right? So class 1A, B, and C are all going to block the sodium channel. The differences between 1A, B, and C are the primary sites of action. So B and C primarily are going to be affected, or are going to primarily affect the ventricular tissue itself. The class 1A agents will also affect atrial tissue. Okay, and then the drug examples are listed here. The class 2 agents are the beta-1 antagonists. Those are going to primarily affect the SA and the AV node. All right. Your class 3 agents are your potassium channel blockers, and those will go after atrial and ventricular muscle itself. And your class 4 agents, like the class 3 agents, because of their effect on calcium, are going to go after the SA and the AV node. And then the prototype drugs are listed here.